Our next speaker is Dr. Shannon Jackson, and she is an adult hematologist at St. Paul's Hospital in Vancouver, and she will be talking about maintaining general good health while aging with mild hemophilia. And I'll just remind you guys that we have a panel at the end of this session, so we'll take a lot of questions at that point, so save them for that.
Thanks, Dr. Rimmer, and great to see you all. I'm thrilled I was asked to talk a little bit about general good health, whatever that means, but trying to frame it within the context of a non-severe hemophilia. And I thank Natasha for the hint, because it's a big topic, so I'm going to stick a little bit to heart health. And I also am going to do more of a commentary and sort of invite some discussion and thoughts and shifting the way we think about aging. I know I certainly am. My major disclosure being for this presentation that I'm gathering increasing expertise with aging personally. So I wanted to frame today by talking about a case. So obviously this is a stock photo and I'm going to use a pseudonym, but it's based on a real patient who has quote-unquote mild hemophilia. We first met him, even though he lived in BC his entire life, in 2021. He's in his 60s, and he was diagnosed at age 6. And as kind of typical for the era, he was followed in his local community at the local hospital where he received the usual treatments for bumps and bruises and dental bleeds. And unfortunately, his general good health started to slide in his 30s. He developed first diabetes. I think he had some degree of obesity, although did not know him at that time. He also developed hypertension, high blood pressure, and elevated lipids. And he came to know his first hematologist in 1995 at the age of 41. And he was brought to St. Paul's Hospital because he had coronary artery disease, and he required treatment for that. He received it successfully. He actually had coronary artery bypass grafting. This was a huge deal back then, to have a patient with hemophilia go through this. But he made it through successfully, and as was pretty typical for the time, he was discharged back to his community. At the time, the hemophilia clinic really wasn't following patients with non-severe hemophilia, being focused primarily on those needs of the severe population. So the story goes on to when we met him in 2021. Sure enough, for the first time, we see him again when his coronary artery disease progressed. And as ever, it was a bit of a reactive moment because things have to happen fairly quickly. And so a lot of things happened to get things in order, and he ended up having, this time, coronary angiography. And he was able to have some balloons and then some stents placed. And it was really, that's when things started to shift, and we actually got to know him, having to support him with some factor VIII during a period of time when he was on dual antiplatelets for about 3 months. His baseline factor VIII was around 10–20%. And ever since, we've been following closely. But unfortunately, he hasn't really recovered his function. The years of having heart disease have taken their toll, and he has some degree of heart failure, and he's then developed some arrhythmias. Now we're getting set up to do a pacemaker. So feeling often at the unpredictable end of some of these events, I was kind of curious as to what our prevalence or how many of these procedures we're doing, like for Stanley. Because to me, it's becoming more common that we're doing these cardiac procedures. So I took a look at our procedural database, which is called ICHIP, in BC over the last 3 years. And I found for our whole population, we did about 850 procedures during those 3 years. I looked for the ones that were invasive cardiac procedures just to see how many we were doing. And it turned out there was 21 during that time. And they mainly fell into 2 categories. Either we were managing arrhythmias, and this could be through cardiac ablation to correct the arrhythmia, pacemaker, or even the insertion of a loop recorder device to record them. And then, like Stanley, patients were having either diagnostic or sometimes therapeutic coronary artery procedures. But that's not really the interesting part. When I looked at who was having these procedures, it kind of was striking. It turned out that 15 out of those 21 patients had non-severe hemophilia, mild hemophilia. And when we think about the whole population, that's about just less than half of our whole hemophilia population. And of our entire clinic, the hemophilia patients represent about just less than half of the total. So this is a fairly significant group who's having more cardiac procedures than others. I wanted to kind of think a little bit upstream. What do we know about prevention? Before doing that, just a quick look at, is this an anomaly? And there's not a lot of robust data sets that look not only at groups with a control that's healthy, but break down the hemophilia into severe and non-severe. And this was a study coming out of the UK and the Netherlands, which about 10 years ago looked at patients who were coming through their clinics and recorded the rate or the incidence of those who had either MI, angina, or ischemic stroke. And then, as you can see, there's a general rate in the population of about 4% of patients over age 30. The severe component of their population, which was about half, had a lower rate than the general population, although this did not reach statistical significance. But what I thought was interesting, and again, not necessarily statistically so, but you see this kind of number inflate when we start to talk about non-severe patients. And to Jerry's point, this is a huge group with quite variable factor VIII levels, but it looks like there is more, of course, in this group, and this is approaching the general population. So again, feeling a little bit like we're very downstream of this. And at times, it's very episodic and rushed to try and sort these events out. What I wanted to do today was think a little bit upstream. We devote a lot of time and energy to managing these things when they happen. But do we have space as the bleeding disorder community to get away from those silos that Susan mentioned and think a little bit more broadly about the whole patient and what their cardiac risk factors are looking like? Perhaps some of you already do this in your clinics. Perhaps as patients you've experienced this in terms of the care received. So I wanted to talk quickly about whether we might have a role to play in heart health, maintenance, prevention, specifically hypertension, and then general health screening. And I do have to credit our nurse practitioners in Vancouver. They push a lot on this in terms of taking care of that piece, and I think it's, I'm starting to get it. and what I'm not sure of is how do we do both? How do we, with our very limited resources in hemophilia care, manage to be the experts and be available and deploy the skills and knowledge we have, but at the same time be thinking more preventatively? And you know, in training, when I learned how to do this, I didn't really do that. I just referred everything back to the GP. You know, the GP will manage this, or we'll refer this back to the community. But our reality right now is that's not always possible. This survey that looked just in the fall of last year, pan-Canadian survey of over 9,000 people, detected that 1 in 5 of us don't have a family doctor or a nurse practitioner for regular care. Sure, we have walk-in clinics, but a lot of people don't. And this was higher in BC, Quebec, and in the Atlantic regions. And I see this, and I actually think it's worse because a lot of people have a sort of a churn of regular family practitioners or nurse practitioners. So it's really hard for them to do this type of preventative treatment. So what do our guidelines tell us to do? In terms of heart health, we can look to our World Federation guidelines for the care of hemophilia that was updated in 2020. And there are some chapters that obviously devote time to treating these things, but they also talk a little bit about prevention and screening. And in terms of comparison to the general population, we know that we're recommended to do the same types of screening for coronary artery disease, which in general in a primary care setting is going to be the application for an individual patient of a cardiac risk score and a subsequent discussion with them about the modifiable cardiac risk factors and how to work on that. The WFH recommends that we also screen patients with hemophilia, not we as the community, but that patients with hemophilia have the same screening as everyone else. And I wanted to point out a little bit about the last one. You guys are probably familiar with most of the cardiac risk factors, but obesity is something that we kind of have an indirect line of sight on, because for all of our patients who are mild or severe, we tend to measure a weight or ask about a weight on an annual and ongoing basis. We don't always collect a height or do the BMI calculation, but could we? And I think this is even more reflected in the guidelines as an expectation that we should be, because if patients are meeting the kind of cut point for overweight or obese, the WFH is recommending that we refer them for dietary advice or weight management. In terms of physical activity, I think we're pretty good at this in terms of knowing what to do and how to speak with our patients. And the WFH certainly recommends that we recommend regular physical activities done in a safe manner. Just to transition a little bit to hypertension, this is high blood pressure. This is typically in the general population a blood pressure between 135 and 140 systolic, higher than that, or higher than about 75 to 80 diastolic. Very common in the population, and what may not be realized by the hemophilia community is that the rates of hypertension are in many different studies shown to be a little bit higher, and up to 50% in some cases, usually in the mid 40s for sure. And I know in our clinic, Dr. Sun published a paper on this, and she was able to do it because we shared the clinic space with the hypertension clinic. So mounted on their wall, they had this beautiful calibrated, kind of fun to use BP True machine together with the collection instructions, and that made it really easy to do that. And we did it a lot. And others have found the same thing. What we didn't do and still don't is intervene with the treatment, the different phases of hypertension treatment that are so well done by our primary care community. I think it behooves us to know a little bit about what the expectations are in terms of measurement of blood pressure as a start, and Hypertension Canada has published these. Both the measurement techniques, so timing, position, the how-to, and then the validated equipment, the what with. And gone are the old wall-mounted, kind of yucky-looking blood pressure cuffs that you're not sure were ever cleaned. In are the automated devices in clinics or offices when you're seeing your clinic team or your primary care doctor, like the BP True, the one that we had. There are also recommendations for more monitoring in the home to really get a better sense of how this blood pressure is doing over time. And many patients can go, I'm told, and buy a home blood pressure kit for $60, $80. But is that a real option for everybody with hemophilia to do? And finally, the ambulatory blood pressure monitoring that is more medically applied and read out as an option. So I think these are good things to know if we are at that place where we can at least detect that there might be a problem. And lastly, I wanted to make this point, and Paul's not here, I was gonna surprise him with a picture, but this is what our clinic looked like pre-pandemic. We would see people in that same space that was shared with the hypertension clinic. Each of us had our own room, and the patient would shuttle between the different rooms, and we had all the blood pressure monitoring stuff there. It was easy. But since the pandemic, we've shifted not only to maybe 20-25% virtual care, because you can't measure a blood pressure doing that, or we've gone to more group visits where we sit as a team with our patient and really perform that more holistic assessment of what really matters to them at that moment. And sometimes I got to admit that blood pressure does not get done. We do the weight, but not always the blood pressure, and maybe that's not necessarily okay. So the last point I wanted to make was about general health screening in patients with mild hemophilia and others. When it comes to age-appropriate malignancy screening that we should be applying over the age of 50, everyone, of course, should get colon cancer screening either through a fecal occult stool test, or through a routine colonoscopy. We often find out about those because of the potential bleeding risk, but we don't necessarily ask if they're being done on a routine basis as what our public health guidelines would be. And of course, for our female carriers, mammography is very important in terms of detection of breast cancer. You know, when I was doing my training, I was kind of used to malignancy screening for those patients who had liver fibrosis, who had developed hepatitis C, and required screening for hepatocellular carcinoma. And that obviously is something that we want to detect early and prevent, and continue to do this with the recommendations usually to do an ultrasound about every 6 months, at least in Canada. Who's ordering that is a great question. And I think a bigger question in our population, and one that we start to think about at large, is not only fibrosis and cirrhosis due to hepatitis C, but the potential fibrosis and cirrhosis due to a really common thing that's happening in our population, which is the development of steatosis in our liver or fatty liver. Some cohort studies would say this could be 1 in 4 people who develop some fatty liver, and if they continue to do so for many years and have inflammation associated, that can also be a risk factor for developing cirrhosis and even hepatocellular carcinoma. And when I start to think about gene therapy, not only in our severe patients, but perhaps at a future of where we could do this in milder patients, this is something that we probably need to pay attention to as an upstream problem that we could potentially get corrected prior to the availability of those treatments. One of the big drivers of this, of course, is alcohol use. And asking our patients how much alcohol, how many standard servings they're consuming per week. Our current guidelines in BC are generated by gender, but many of you probably saw the press earlier this year by the Canadian group on substance use, who broadly, did some consultation, and their advisory group actually suggested for all of us it should be less than 3 standard servings per week. So that's, the kind of thing that we need to be aware of, and our patients may come asking. All right, so I wanted to get back to Stanley because I didn't tell you the whole story at the beginning. I alluded to it a little bit. So Stanley is now very engaged with our clinic, but it wasn't always the case. And I have these beautiful old charts with the little sticky notes that our clerk wrote on them every time she tried to contact him to come to clinic, and every time he said, no, thank you. And I think going back to the patients with non-severe or mild hemophilia, this is a risk for how we may not be very effective at doing preventative screening. So just for fun, and he really likes healthcare people. He had nothing against us specifically, but he just really didn't want to waste our time. He had been programmed to believe that, hemophilia clinic was for people who had bleeds. And when he didn't have a bleed, why would he go? And so also wanting to open up that resource for other patients who were more severe was what his motive was. And about 10 years later, he said, coming to clinic doesn't benefit me. And even if you try to convince me, I won't come. So he was very honest about it, and I think that's great. And we were finally able to get him by only attending clinic on Zoom the first go. Now he's good, but it was really an effort. And I think that this underlies some of our challenges as a community to try and close. And I love this book that the CHS prepared. I think it's absolutely necessary, and we need to have more conversations. And I also love mnemonics. So for those of you who saw Dr. Pike's presentation, she did this period mnemonic. I have one too. And it's really about milds. The fact that, as we already heard, there's a general minimization of the potential problems that could arise, both from the patients and the way they've been messaged growing up, like Stanley, and actually the healthcare providers who see the word mild. Often, like Stanley, they come in and we don't have the full story in terms of the investigations we need to act quickly to try and give them the best outcome from their presentation. Often, if they were ever connected in the first place to clinic, they're lost to follow-up. And I think Erica's presentation this morning really talked about how that is so much more common. The diagnosis is often delayed, not only until adulthood, but sometimes late adulthood. When we find one Stanley, we sometimes find a couple other brothers out there. And lastly, as I know that Joanna will probably talk about, the signs and symptoms of bleeding are just not as familiar. So we've got some work to do in our community. So in conclusion, obviously general good health is worth maintaining for all of us. I think heart health, hypertension, and health screening are something we need to really consider as a bleeding disorder community and infuse into our conversations. I'm curious to hear how you're doing this, and I invite new research, partnerships, discussions, and educational efforts to try and close that gap. Thank you.